Okay, so today we're going to be covering hematopoetic function, and this integrity lesson is specifically on disorders of white blood cells and lymphoid tissues. The hematopoietic system and lymphoid tissues are responsible for the generation and regulation of the blood cells that function in the transport of oxygen, in the defense against microorganisms, and in the preservation and integrity of the vascular system. So that's kind of what we're going to be talking about. This is their introduction and review of some of the normal or leukocytes and what they include and how they normally function. The blood consists of blood cells, okay, leukocytes or white blood cells. Also, we'll talk about later thrombocytes or platelets, and then erythrocytes or red blood cells. Our lessons today focus mostly on the leukocytes or the white blood cell. When we talk about leukocytes, they're usually derived or made up in the bone marrow, and then they will travel out to the tissues as necessary when invaders invade our system or whenever they're needed in other places. So, we're going to talk about first granulocytes. Again, we look at leukocytes, can be broken down into granulocytes and agranulocytes. Leukocytes originate in the bone marrow and circulate through the lymphoid tissues of the body. The granulocytes, they are all phagocytic cells, okay? So they have what we call granules on them that are phagocytic, so they destroy. The neutrophils are the first type of granulocyte, and again, I think in class I told y'all they're responsible for maintaining normal host defenses against pathogens that have breached our physical barriers, which are our first lines of defense, the skin and the mucous membranes. These neutrophils have enzymes that will destroy a foreign substance and then mediate the immune response. So neutrophils, in a sense, are our first responders to an infection or to an invader. And they actually take up about 60 to 65% of the entire white blood cells or neutrophils. They only last in the blood system about 4 hours in the circulation before they move into the tissues, and then they can survive in the tissues for a few days. But they're the first ones out to defend us, first responders. And they come out in large numbers usually, but they don't last very long. The eosinophils, we'll look at those. We'll see an increase in eosinophils during an allergic reaction or parasitic infection. And in the basophils, you need to understand that these granules contain heparin, which is an anticoagulant. They also contain histamine, which is a vasodilator, and other mediators of inflammation. And again, basophils play an important role in allergic reactions as well. Your lymphocytes, these are agranulocytes, meaning they are leukocytes that lack a cytoplasmic granule. And we're going to talk about these being lymphocytes and monocytes. The lymphocytes, however, are the most common of the agranulocytes, and they account for about 30% of the total blood leukocytes. They originate in the bone marrow again, and from the lymphoid stem cells, and they migrate through the peripheral lymphoid organs. They function in the lymph nodes or the spleen, and they defend against foreign microbes in the immune response. You further break down, there are 3 types of lymphocytes that you can further break down. B lymphocytes or B cells, T lymphocytes or T cells, and then the natural killer cells. Remember that your B lymphocytes deal with humoral immunity, humoral-mediated response, meaning that the body will produce antibodies. Your T lymphocytes differentiate in the thymus, and they activate other immune helpers T cells, and then your natural killer cells participate in innate or natural immunity, and their function is to destroy foreign cells. Most of the disorders that we're going to talk about in this lesson are dealing with the B lymphocytes or B cells. The monocytes, or the macrophages, which is the last type of lymphocyte, they're the largest of the white blood cells. So they're big and bad, and they come out, and they're the biggest, and they engulf the bacteria. They're late responders. They don't come out in the beginning. They kind of take some time. They're big, so there's a little bit slower. That they come out and live about 1 to 3 days. They ingest the bacteria, and then they begin to die. You can kind of look at a little bit more detail about this in your chapter, but really most important is just kind of having an understanding of what these do in normal function. So where we start getting into the material in your objectives is when we talk about non-neoplastic disorders of the white blood cells. Non-neoplastic meaning not cancerous. And the two that we talk about mostly is leukopenia, neutropenia, and infectious mononucleosis. So neutropenia. The term leukopenia is something you need to be familiar with, and that's an absolute deficiency in white blood cells in the blood. The term neutropenia, or the other term is agranulocytosis, is a significant decrease or absence of neutrophils. And that's really important because the neutrophils, remember, are your first lines of defense. And if we don't have those, then the patient cannot have their first line of defense is down, and they can't fight off infections, right? So what we see is some of the causes would be like chemotherapy or any kind of bone marrow cancers. Aplastic anemia is one, and also some autoimmune disorders. Neutropenia is commonly defined as a circulating neutrophil count of less than 1,500 per microliter of blood. Now, we know that the severe reaction or severe case would be if there was less than 500 per microliter of neutrophils per microliter of blood. So the biggest thing here is you can see by the pictures, this patient is prone to infection. You have a sick fish. You're protecting the patient from anything that you could bring into the room, any kind of bacteria that you would have on you or in you. So, the clinical course of neutropenia. The clinical features of neutropenia usually depend on what's causing it, okay, and how severe it is. Neutropenia from any cause, like we talked about chemo or cancer or any of those, actually places the patient at risk for infection, okay, from any kind of bacteria, fungi, anything like that. So we know that patients that don't have neutrophils are at risk for infection. Skin infections and oral infections, mouth lesions are the most common sites that we see affected, but the most serious site is the respiratory infections because the usual inflammatory response is not there. But nevertheless, if we see a fever in someone with neutropenia, we should always assume to be infectious of infectious origin. Okay, infectious mononucleosis. Couple of important things here. It is a self-limiting lymphoproliferative disorder, usually caused by the Epstein-Barr virus. It's important, EBV virus, which is a member of the herpes virus family. It can occur at any age, but it's most common among adolescents and young adults due to the primary method of spreading, which is via oral secretions. That's why we call it the kissing disease. The onset is insidious due to an incubation period of 4 to 8 weeks. So you might be infected today and you won't show any signs or symptoms for up to 1 to 2 months, okay? So the virus actually invades the oropharynx, the nasopharynx, and the lymph tissues, and then it spreads to the B lymphocytes. Okay, so Okay, so it spreads to the B lymphocytes. Then the T lymphocytes and the natural killer cells are activated, and the lymph nodes become enlarged. And they house all of those infected cells, and so they begin to swell. Okay, so the clinical course of the disease, the onset of infectious mononucleosis is usually, again, insidious. I told you that because there's an incubation period, 4 to 8 weeks. What we see is a prodromal period. It's characterized by malaise and anorexia and chills. Typically in this period at this time, there's no fever, no sore throat, but those things are yet to come. So it's important. Once someone has fever, sore throat, those kind of things, we're no longer in the prodromal period, okay? Other manifestations, you see the anorexia, fever, chills, pharyngitis, which is, sore throat kind of thing. Hepatitis and splenomegaly are very common, so the enlarged liver, nausea, anorexia, and jaundice. If they have liver involvement, you might see this patient have some yellowing of their skin and jaundice. This acute phase lasts only 2 to 3 weeks and has then a rapid recovery. So it's self-limiting. It takes care of itself. What labs would you use to confirm a diagnosis of infectious mononucleosis? Your book doesn't give a whole lot on the diagnosis. It just talks about there being an increased number of leukocytes with white blood cell count between 12 and 18,000. The rise in the white blood cells began during the first week. They continue during the second week of the infection and then return to normal around the 4th week. So that's really all your book kind of talks about. So that's what we'll go with for the diagnostics. So keywords that you want to remember with this one is self-limiting, Epstein-Barr virus, kissing, insidious. They have lymph node enlargement, fever, malaise, and upper quadrant pain. And again, you have this slide that gives you all the signs and symptoms as well. Now we're moving on to the neoplastic disorders, or the cancerous disorders of the hematopoetic and lymphatic origin. So, we are not really covering myeloid leukemias. We're going to cover mostly the acute lymphoid leukemia and the chronic lymphocytic leukemia. So what you see here is we talk about white blood cells are formed and they differentiate in the bone marrow. I explained differentiation in terms of a child growing up. Like a 5-year-old would not be differentiated. All 5-year-olds are pretty much the same. They don't know what they want to do in life. So they're non-differentiated. They're not different from each other. 25-year-olds, we're well on our way, kind of have an idea of what we're going to do. We're working at it. We're more adult, more geared to do specific functions. We know things to do, and so we become more differentiated. And your elderly patient or anyone over 50 might be a completely differentiated, so to speak, cell that knows exactly what their function is. They do exactly that function every time. So that's kind of how differentiation works. So white blood cells are actually formed in the marrow, and they differentiate in the marrow. And then they travel, and they travel to the lymphoid organs where they become mature, and they develop. And what we see is typically like cancers or neoplasms that arise through either the method of traveling or once they get into the lymph nodes. Then we have the lymphoid leukemias and lymphomas. Okay? So let's talk a little bit about leukemia. So leukemia means white blood, right? It's malignant neoplasm of the hematopoetic stem cells. So let's go and see. The lymphocytic leukemias involve immature lymphocytes and their progenitors that originate in the bone marrow but infiltrate into the spleen, the lymph nodes, the central nervous system, and other tissues as well. We talked about lymphocytic versus myelogenous. So the lymphocytic cells are the ones like I just told you about there. The myelogenous cells, they involve myeloid stem cells in the bone marrow, and they interfere with the maturation of all blood cells, including your granulocytes, your erythrocytes, and your thrombocytes. So that's kind of the difference. But we're going to be focusing on lymphocytic leukemias. Acute and chronic, basically, acute is poorly differentiated. Chronic is well differentiated. So acute, young, chronic, old. Okay, most common leukemia in adolescents and children would be acute lymphocytic leukemia. Most common leukemia in adults would be chronic lymphocytic leukemia. Okay, so ALL. ALL, acute leukemias are cancers of the hematopoetic stem cells characterized by the overproduction and accumulation of cancerous, immature white blood cells, known as lymphoblast, with a sudden onset of signs and symptoms related to depressed marrow function. Remember, your bone marrow is important in production of red blood cells and the production of the let's just hold off on that. So, if we don't produce red blood cells, then we're not going to have enough circulating. We can be anemic and things of that nature. In persons with ALL, lymphoblasts are overproduced in the bone marrow and continuously multiply, causing damage and death by inhibiting the production of normal cells, such as red blood cells and white blood cells and platelets. These things aren't produced because there's such an overgrowth of the lymphoblast in the marrow. And then they spread, infiltrating to other organs. ALL is the most common in children and adolescents, with 3 out of 4 being diagnosed with ALL. Most cases, 85% are pre-B cell origin. So remember that the B cell are responsible for humoral immunity. Okay, and which is an antibody-mediated immunity. So if there's a problem with the development of those cells, the patient can't produce antibodies to fight off an infection. Blood and bone marrow studies will use to get a diagnosis of leukemia. A definitive diagnosis of acute leukemia is based on blood and bone marrow studies. It requires the demonstration of positive leukemic cells in the blood, the bone marrow, and the extramedullary tissue. They'll do a bone marrow biopsy to determine the molecular characteristics of the leukemia and the degree of bone marrow involved. Okay, most of the time we'll do a bone marrow biopsy to confirm a diagnosis of the molecular characteristics. They also may do a lumbar puncture, and that would be done for staging of the disease. And again, CT scans can be done to assess, like if other areas have become infected. So in acute lymphocytic leukemia, the staging includes a lumbar puncture to assess for central nervous system involvement. Okay. So let's look at chronic leukemia, or chronic lymphocytic leukemia. This is chronic leukemias are malignancies involving proliferation of more fully differentiated cells, older cells. They know their functions. One-third of all leukemias, mainly in older persons with an average age of 72, and we rarely see chronic lymphocytic leukemia in someone less than 40. In CLL, what we see is a chronic lymphocytic leukemia is a clonal malignancy of B lymphocytes. It's the most common form of leukemia in adults in the Western world. B cells grow in an uncontrolled manner and accumulate in the bone marrow and the blood. Basically, they crowd out the healthy blood cells and enable the body to produce specific antibodies to fight infection. The clinical signs and symptoms we're going to talk about of CLL are largely related to the progressive infiltration of the bone marrow and the lymphoid tissues. Diagnostics, again, the book is pretty vague, but it talks about a hallmark of CLL is isolated increase in lymphocytes. The white blood cell count is usually greater than 20,000 per microliter of blood and maybe even elevated to several 100,000. 75 to 98% are lymphocytes. So, symptoms of leukemia. You have the word ant. You have anemia, neutropenia, thrombocytopenia, which we're going to talk about. Neutropenia. Remember, no neutrophils to fight off the bacteria, so they are at risk for infection. Anemia. Now we talk about leukemia as being an overgrowth of these B cells, which is kind of takes the place of all the good cells, so that they don't have there's not enough hemoglobin circulating. Okay, and the thrombocytopenia places them at an increased risk for bleeding because of low platelet counts. So leukemias, I want you to think immature or acute leukemia, I should say that. Numerous immature white blood cells like ants in an ant colony. Chronic, they're more differentiated, they're older. Okay, acute, younger, less differentiated cells. So what are some of the warning signs? Warning signs would be fatigue, pallor, kind of like the paleness, weight loss, if they have repeated infections and they bruise really easily, or they have nosebleeds that weren't, common before. So with acute, some of the manifestations, you see the fatigue because the patient is really anemic. So the anemia in the patient causes them to be tired and fatigued. They have night sweats and fever and weight loss. And these are due to a rapid proliferation and hypermetabolism of the leukemic cells. They have bleeding that's due to low platelet counts. We'll see bone pain and tenderness due to marrow expansion. We still in acute, we see risk for infection due to neutropenia, especially if the neutrophil count is less than 500 cells per microliter. Really big risk for infection. Then we see lymphadenopathy and splenomegaly and hepatomegaly. Again, this is due to the over-infiltration of leukemic cells in these patients. And then lastly, we'll talk about central nervous system involvement. You might see headache, vomiting, nausea. You might see some papilledema, which is swelling around the eyes. Okay. What else? Let's see. You might see like cranial nerve palsies, where some of the cranial nerves begin to shut down when we have the central nervous system involved. So those manifestations are on page 251 if you want to kind of look over those and get a better understanding of why these things occur. Okay, but the big thing here is that the patient's usually anemic. They are at risk for bleeding, at risk for infections. They're very uncomfortable. They're very tired. Okay, with acute, we see a sudden onset. With chronic or CLL, we see manifestations that are related to the progressive infiltration of bone marrow and lymphatic tissues by the cancerous lymphocytes. Most patients are asymptomatic, meaning they don't feel bad at the time of diagnosis. And the elevated lymphocyte count on their routine blood work is the only indication that they're sick. But as it progresses, they begin to have lymph node enlargement, again, weight loss, night sweats, and fever. These often have more abdominal pain because by the time that things have kind of progressed, They have more likely of the hepatosplenomegaly to occur. And then we'll see anemia and thrombocytopenia and all those things as well. When we look at the chronic nodal involvement with these patients, your book also talks about it can be in unusual areas, lymph nodes that are becoming involved, like the scalp, the eyes, the pharynx, the lungs, and so forth. There's many lymph nodes that we have that can become involved. So, again, this was one I asked y'all to kind of think about and ask yourself, can you explain why a patient with leukemia would experience bone pain and fractures? Okay, again, we focused a little bit on these things as we went through each one of the manifestations already. Can you, we talked about all the lymphoblast growing in the bones and overloading, putting pressure and causing excess growth of those. So that can cause pressure. Anemia, remember, it's kind of for the same reasons. The fatigue is due to anemia. Can you explain why they experience anemia? Of low hemoglobin counts. This is just a couple of things. I mean, there's plenty more things that you can go and look for. Why would a patient with leukemia have immunosuppression and thrombocytopenia? So these are good areas for you to think about, and if you can answer those, I think you have a good knowledge base on this information. Okay, so let's talk about malignant lymphomas, which is non-Hodgkin's lymphoma and Hodgkin's. So non-Hodgkin's lymphoma is one of the most common cancers in the United States, accounting for about 4% of all cancers. The average American has a risk of developing non-Hodgkin's lymphoma during his or her lifetime of about 1 in 50. So one person out of this class is likely to develop non-Hodgkin's disease. 95% or more than 95% of the cases occur in patients over 65 years of age. There is an evidence of correlation with Epstein-B virus infection, essentially in all people with something called Burkitt lymphoma, which we're not really kind of getting into. So the nodes that are involved are what we call multinodal involvement, that it's dispersed kind of throughout the whole entire system. So you might see lymph nodes in the groin area, but you might also see like an axilla lymph node involved. So it's kind of spread out, if you will. It's kind of everywhere. But the patho part of it, they originate from malignant transformation of either the T or B cells during their differentiation in the peripheral lymphoid tissue. Although the non-Hodgkin lymphomas can originate in any of the lymphoid tissues, they most commonly originate in the lymph nodes. Okay. So we can see this in BRT cells, and it kind of can be anywhere in the lymph nodes. So we'll see it kind of diffuse and throughout the body. The diagnosis, a lymph node biopsy is used to confirm the diagnosis, and we'll do some different kind of other markers and things to figure out what kind or what type of lymphoma the patient has. You might also see bone marrow biopsies or blood studies, chest x-rays, CT scans, MRIs, things like that. All those can be used. They'll do like a bone scan to be used to determine the stage of the disease. But typically a biopsy of a lymph node is what we need for a diagnosis. Okay, and that biopsy will be positive for neoplastic lymphoid cells. And that's how we know they have non-Hodgkin's, along with their signs and symptoms and those type of things. So Let's look at Hodgkin's lymphoma. Now, Hodgkin's lymphoma is previously known as Hodgkin's disease. It features the presence of abnormal cells called Reed-Sternberg cells. Very important to understand in here. If you ever see Reed-Sternberg cells, you're looking at Hodgkin's lymphoma. Okay, basically the distribution of the disease is what we call bimodal. It occurs most frequently in two separate groups. The first is in early adulthood, so 15 to 40-year-olds, and the second is in older adults, 55 and older. The way that I look at it is really, if you're looking at 15 to whatever, it's really any age can occur. Okay, but it does happen in a bimodal fashion, so it happens more in those two age groups that I gave you. But the key thing here is that it's usually a single node that's involved, or a group of contiguous tissues. So the tumor itself, like in this picture, this might be one lymph node, and this is all tissues that are connected to that lymph node, so contiguous. You wouldn't see in Hodgkin's, you wouldn't see an enlargement here, and then an enlargement in their axilla, an enlargement in the groin. You would just see the enlargement in one area. First, Hodgkin's lymphoma arises in a single node or chain of nodes and spreads first to the anatomically contiguous lymphoid tissues. When we talk about diagnosis of Hodgkin's lymphoma, a definitive diagnosis of Hodgkin's lymphoma requires that Reed-Sternberg cells be present. So if you do a biopsy of the lymph node tissue and it doesn't have Reed-Sternberg cells, then it's not Hodgkin's lymphoma. It will have those cells in it if it's Hodgkin's lymphoma. They also do CT scans and other PET scans or bone scans, to see about staging and how involved the rest of the tissues and the organs are and how to treat it. So let's look at signs and symptoms of or manifestations of these two, Hodgkin's and non-Hodgkin's. We've already talked a little bit about the enlarged nodes in both, and so you should have a good understanding of that. In non-Hodgkin's lymphoma, the manifestations depend on the type. So if it's what we call indolent or aggressive type, people with indolent or slow-growing lymphomas usually present with a painless enlarged lymph node. Okay. So they could be isolated, it could be widespread. We usually see these painless enlargement of the lymph nodes, okay? We know that these indolent lymphomas are usually disseminated at the time of diagnosis and that bone marrow involvement is frequent. So it's kind of dispersed in somebody with non-Hodgkin's lymphoma. It's kind of throughout your whole lymphatic system. When they have the more aggressive form, it's usually present with accompanying symptoms such as fever, drenching night sweats, and weight loss. There's usually an increased susceptibility to bacterial, viral, and fungal infections because there is a hypogammaglobulinemia and poor humoral autobody response. Okay, so there's not a whole lot of the gamma globulin circulating, and so this patient is a high risk for infection. They can't build antibodies up against things. So when we look at Hodgkin's lymphoma, on the other hand, its manifestations would be like, again, a painless enlargement, but in a single node or a specific group of contiguous nodes or tissues. And again, these are typically seen above the level of the diaphragm. So like the neck, the supraclavicular area, the axilla, you may see complaints of chest pain or cough or dyspnea. May see fever, night sweats, chills, all the same things that you saw in the other one. But pruritus is something that you see with Hodgkin's that you don't necessarily see with non-Hodgkin's. The cause of this itch is not definitely known. It is believed that some blood cells release chemicals near the nerves of the skin and irritate those nerves. We feel this as an itch. The The pruritus and the intermittent fevers associated with night sweats are classic symptoms of Hodgkin's lymphoma. Other symptoms, again, fatigue and anemia are indicative of the disease that it's spread. And in the advanced stages, the liver, the spleen, lungs, GI tract, and sometimes the central nervous system can be involved. Okay. So let's look at multiple myeloma. Multiple myeloma is a B-cell malignancy of terminally differentiated plasma cells. These plasma cells are old. Okay? These are terminal differentiated plasma cells. It counts for 1% of all cancers in the Western countries. It's higher in men and people of African American descent. It occurs most frequently in the elderly, with an incidence peaking at 63 to 70 years of age. It's characterized by a proliferation of malignant plasma cells in the bone marrow. And I want you to understand this osteolytic bone lesions, because we're going to focus here on osteoclast. This is where they're going to break down the bone. Okay? What we talked about before was the osteoblast, where they were building more and more and more and putting pressure inside the bone marrow because they were building more and increasing numbers. In this situation, what we're going to see is osteolytic bone lesions throughout the skeletal system. So the destruction. Okay? One of the characteristic features resulting from the proliferating neoplastic plasma cells in multiple myeloma is an unregulated production of abnormal monoclonal paraprotein referred to as the M protein. It's detected as an M spike on a protein electrophoresis, and basically we're seeing either IgG or IgA. Okay? When you see light change, or when it's excreted in the urine, it's called Bence-Jones proteins. Bence-Jones. So if you see Bence-Jones proteins, or you talk about an M spike, or M proteins, we're talking about multiple myeloma. These are classic things for this disease. Okay? The main sites that are involved in multiple myeloma is the bone and the bone marrow. There's a proliferation and activation of osteoclasts, which lead to bone resorption and destruction. Because of this, we have pathologic fractures and hypercalcemia. Okay, so in the picture you see the bone pain usually in the back and the ribs, or broken bones in the spine, and this is like, I'm talking people who like cough and they cough and they have a fracture in their spine, or they throw a fishing pole and they fracture their vertebra. This is not some things that should be fracturing your vertebra. Okay, they have very high concentrations of these paraproteins, those M proteins. And because there are so many of those, the blood is very thick and viscous. So you have hyperviscosity of the blood. So it's thick. Okay? Because of those Bence-Jones proteins, you have the kidneys who become involved. And we'll have 50% of the patients will have renal impairment, evidenced by elevated BUN and creatinine, which we've already covered, okay, in those renal section. So the acronym CRAB, which is calcium elevation, renal impairment, anemia, and bone pain, and fractures and things like that. CRAB is a good acronym to remember for multiple myeloma. Okay, it'll help you kind of understand and remember the signs and symptoms that you're going to see. These patients are also at risk for recurrent infections and thrombocytopenia, which again we're going to get to in just a second. I'll tell you what that is. Okay, and that's going to actually, I'm going to make another PowerPoint for the alterations in hemostasis, so that's going to conclude.